Well, we have many different types of hernias in the abdominal wall, and these can be categorized in various ways or upon various factors. For instance, location. We have ventral hernias, which occur on the front of the abdominal wall, or flank hernias that develop on the sides of the abdomen, or groin hernias if they develop on the groins. We have also pelvic hernias, which are a bit more complex and occur in the pelvic region. Now, hernias can also be categorized by cause if they are congenital hernias that are present from birth and are due to an inherent weakness of the abdominal wall. And a typical one would be the umbilical hernia. But can be also acquired hernias, which develop a long life. And there are many factors that can increase those risks of developing an acquired hernia, such as obesity, such as previous surgery, trauma, very heavy lifting, or increased abdominal pressures, which there are certain diseases that increase the abdominal pressures, such as liver disease, amongst many others. Well, I would just go, if I may, allowed just a step back. I would like also to infer something that may be very well known or not so well known, and it's that males tend to be 10 times more likely to develop hernias than females throughout their lives. And this reason is amongst many due to anatomical differences, but also due to increased intra-abdominal pressures, because the males do have an increase in abdominal pressures, and also they do different types of jobs, which some of them are more involve more strenuous work loads. But going into the symptoms of abdominal wall hernias, I would say that the commonest would be a visible bulge. A bulge that not necessarily is painful or uncomfortable, but maybe just gurgling bulge. It may well be that it's uncomfortable or painful. Often this is more related to a burning sensation. This is the commonest symptoms. Less common would be patients that come into hospital in an emergency setting with an incarceration, for instance, which is when a hernia has some tissue within it stuck painfully outside within the sac. But it could be also obstruction if the tissue that has got stuck outside within the sac of the hernia is bowel, and this often comes with abdominal distension, perhaps vomiting, perhaps inability of passing wind or opening the bowels, or indeed a lot of crampy pains in the abdomen. The worst scenario, of course, is whether patients come in with a bowel that not only is stuck inside of the hernia and obstructed, but that the blood supply to it is cut off. And this is potentially life-threatening because, of course, lack of blood supply to a tissue will render it dead, ischemic, that we medically call it, and ultimately would lead to death of patients. So this is an absolute emergency. Now, on this point, I would like to make a clarification, because people get very scared with strangulation of hernias, but the reality is that there is enough evidence to suggest that strangulation at 18 years of age would happen in 1 in almost 400 patients, which that accounts roughly about 0.27%. Now, this is an exceedingly low risk for strangulation. That is on an 18-year-old adult. If an adult was 70 years of age or above, this is 1 in 3,000, which makes it almost negligible. And therefore, there is very little chances, really, of suffering from strangulation. Well, that is a very pertinent question. A recent randomized controlled trial in the UK that was looking at patients with minimally symptomatic hernias, the study showed that a watchful wait approach was safe and appropriate in some patients. However, the same study pointed out that during a 10-year period or 7-year period, up to almost 3/4 of the patients crossed over to from watchful wait to surgery. So what you can, and what this means is that what you cannot take away is that when a hernia is present, this hernia will never go away and will there is a disease progression. And the speed of progression will depend very much on environmental factors and levels of physical exertion of patients and other risk factors. Now, if we look at hernias that are completely asymptomatic, that is, hernias that do not cause any trouble whatsoever, especially if they're very small. These are often, and the general consensus is to offer these conservative management, and that this is based on the principle that surgery carries risk. And patients with very small and non-symptomatic hernias, the benefits of repairing these hernias do not outweigh the risks, particularly the chronic pain that you may inflict from surgery. So in these cases of asymptomatic hernias, patients, a discussion needs to be made with patients so that they can make an educated or an informed choice. You have to understand that ultimately the goal of a hernia repair is to improve the patient's quality of life and, of course, prevent complications. But there's two sides of these. The first, preparing for abdominal wall hernia surgery involves both patients and healthcare providers or healthcare staff, and that is not just surgeons, it's anaesthetists and definitely nurses. Patients are invited for a pre-op assessment, and during which they go through the procedure itself. Leaflets, informative leaflets have been handed over in terms of what the surgery that they're going to go under entails, but also all the other guidance on how to be best prepared for these surgeries, such as personal hygiene, avoid smoking if at all possible for a week before surgery, the policies of staying nil by mouth or just sips of water until surgery, and also, of course, withholding certain types of medication, such as blood pressure tablets, diabetic drugs, or blood thinners. All this is covered in this pre-op assessment, which is really essential to prior any surgical procedure.